Welcome to this presentation on virtual care. My name's Dr. Kevin Sampson. I'm a family doc. I've been doing virtual care since well before the pandemic, so I can offer an experienced clinical perspective. Take a moment, think about virtual care. Make a mental note of what you think it is, what it's best used for, and how it might fit into your medical practice, whatever that might turn out to be. Is it a good thing? Was it just to help us get through the pandemic? Lots to consider, lots to learn. So here's what a lot of people think of when they think about virtual care.
And now I'm going upstairs to the bathroom to talk to Ellen.
Listen, they're auditioning for America's Got Talent right now. You haven't announced if you're coming back for the next season.
My phone's coming again. I'm sorry. Okay. Yeah, no, hang on, sir. Yeah, I know. So you're running a little late, Ellen. Wait, one second. I made a telehealth appointment for like when this was finished. This is my doctor. Look, I'm on Ellen. I can't talk right now. It really is. Wait, what? I have to go. Can I call you after? No.
Do you still have that burning breath?
No, nothing's burning. No, it doesn't burn. It's my doctor.
Did you use the salve?
I used the salve. I did use the salve. Ellen, look, this is my doctor, Dr. Murphy.
Hi, doctor.
But I feel bad. There shouldn't be three of us in this meeting. Can I call you? I'm calling you right back. There's no burning. I used the salve. Okay.
Can I ask you, is he gone? The doctor's gone?
He is. I can get him back.
I was going to ask him some questions.
Okay, let's ask him some questions. I'll get you back. I'll get you, because maybe, now I'm nervous. Why would the doctor call me? You know, when you get a call from your doctor, let me see. Ellen, Dr. Murphy, Ellen wants to ask you some questions. Here.
Hi, Ellen.
Hi, doctor. How long has he had the burning, itching thing?
No, this is not. HIPAA, he can't talk.
Delighted to respond.
No, you're not delighted to respond. Do you have any other questions, Ellen?
Delighted to respond. You know, over the years, he's had a lot of problems I grasped.
No.
All right. Hey, listen, I love talking to you all the time. Stay healthy, stay safe, and I'll talk to you soon, I hope.
You too, Ellen. I love you. Please stay safe, stay healthy. The best to everybody there.
All right. Love you back, Howie. All right, we'll be right back. Howie.
That's definitely part of it, but virtual care is about much more than just video visits. So let's start by talking about what is virtual care. There are a number of good definitions out there. One of the most quoted was adapted from an article in the Journal of Telemedicine and Telecare in 2018. They define virtual care as any interaction between patients and or members of their circle of care occurring remotely using any form of communication or information technologies with the aim of facilitating or maximizing the quality and effectiveness of patient care. Virtual care can include phone visits, video visits, emailing and secure messaging, texting, patient portals, online bookings and online questionnaires, e-referrals, e-consults, remote patient monitoring, and more. We're also seeing medical chatbots coming online. We're going to go over the various forms of virtual care from a practical clinical perspective, pros and cons, appropriate use, optimal use, equitable use, and billings, with a bunch of real-life examples thrown in. Let's start with virtual visits. Virtual visits are not for everyone and not for all situations, but there are lots of times when virtual visits can actually be preferable. Here are some reasons why patients might prefer virtual. It could be difficult to attend an in-person appointment. Finding the transport, being able to afford the appointment because they have to take a bus or a cab or miss time from work. I had an older patient who was riding his bike to see me, even in the winter. I didn't know for quite a while. He had a phone though, and even access to Wi-Fi. Once I realized we were able to do more visits virtually. Time is also a factor for lots of people. A 15-minute appointment can take a few hours out of your day when factoring in getting back and forth and wait times. Rather than trying to take a chunk of time out of a workday or away from other responsibilities, people can just set aside 15 minutes for virtual visits. Some people have a hard time with mobility. It can be difficult for them to get out of the house and to get to the office. Sometimes people with mental health issues can also prefer virtual, having the visit in the safety and security of their own home. When patients are in remote areas or the physician or services required are not local, virtual can provide access that would not otherwise be possible. At Healthcare Excellence Canada, we're currently rolling out a project using virtual care to improve access to healthcare in northern, remote, and Indigenous communities across the country. Virtual also has the advantage of allowing family members and caregivers to join the visit that they would not have been able to attend in person for various reasons. And virtual can certainly be more convenient. Imagine that you're a single parent with 3 young kids and you need to see the doc about some concerns about side effects on the meds that you're taking. Compare a phone call or video visit from home to having to get the whole crew to the office. These are just a few reasons why patients might prefer virtual visits and why it's on us to be able to offer them. So if we're going to do virtual visits, should it be phone or video? Sometimes phone's better and sometimes video's better. People are used to phone calls. Some people don't have access to video, either because they don't have a device to use or access to Wi-Fi or data. Some people don't think they are tech savvy and are reluctant to try video, so they prefer phone. A lot of the video systems these days, though, are quite easy to use, and at my office, we always let patients know that if the video doesn't work, the doc will just call them right away anyway. And people are nicely surprised when they find they can do the video. People who haven't experienced a video visit might prefer phone calls because they don't really know what they're missing. They think the phone is good enough, which it can be, but they're missing out on some of the benefits of video. Speaking of which, video can be more personal. We get to see each other's expressions and body language. Patients can show us stuff like rashes and where it hurts, or how much they can move their shoulder. And people are getting used to the videoing with family and friends and for work meetings. So let's start with phone calls. There's lots of situations in which a phone visit can be really helpful. My first experience with virtual care was years ago on snow days. My office is out in the country, so on really snowy or icy days, we'd have to cancel our clinic. I could remote in to the electronic medical records, or EMRs, from home though, so I'd call patients who were scheduled to see me that day to reschedule their appointments. I was surprised to find though that quite often I could just help them over the phone and wouldn't need to reschedule. Following up on test results, or changing medication, or even counseling for mental health issues. Patients really appreciated the calls, and in a lot of cases it was actually better for them to be able to just have a phone call rather than have to come to the office. As we got into the pandemic and started doing more on the phone, I started running into a recurring problem when I was working remotely. I was blocking my caller ID so that patients wouldn't get my number and just be able to call me anytime. So patients weren't picking up because it looked like I was a telemarketer. This happened quite a lot. It got frustrating and patients weren't happy because they didn't realize that I had called. I don't have this problem anymore though. Phones have evolved from landlines to cell phones to smartphones and now soft phones. Soft phones use the internet for phone calls and run on devices like smartphones and computers. We're using a soft phone system at my office and it's working really well. I downloaded an app on my smartphone, and when I make calls to my patients, it looks like I'm calling them from the office, so now they pick up. Also, calls coming into the office can be automatically redirected to whatever phone we're using at the time, which is making it easier for receptionists and other staff to work from home. Video visits. They can be easy, efficient, and effective when done well and in the right situations. But video visits are still being underutilized. A lot of docs have found them to be tricky and extra work compared to phone calls. There's also usually a cost for video visit software. The technology has improved now though. They can be just as easy and often better than phone calls. A key point when choosing a video visit solution is integration. Some video visit systems are completely separate from the EMR. You need to open them separately and log in, maintain a separate schedule, and type in patient names and details about the appointments. And then you have to juggle screens between the video and the EMR. It was like this when I first started doing video visits before the pandemic. These systems are less expensive and some even free and can work well for some practices, especially where the volume of video visits isn't high. But they aren't great for busy practices, especially in primary care. There are also partially integrated video systems. This is where the video visit solution is separate from the EMR, but at least it communicates with the EMR. So it automatically pulls in the schedule and patient information and allows you to start the video visit from inside the EMR. The two systems fit together. This is like the system that I'm using now. It's more efficient than the non-integrated solutions, but it still means that you're juggling between applications and screens. I found that it works best for this if I'm using two screens, one for the video and the other for the EMR. Depending on where I am, I'll either use an external monitor or my smartphone for the second screen. And now there are fully integrated systems. These are EMRs which have been designed to include virtual care tools like video visits built right into them. A real advantage of these is that the video can be shown in a section of the patient chart, so everything can be in the same window. This is much more practical to use because you don't need to split the screen or use two monitors to be able to see the patient in the chart at the same time. Functionality is also an important factor. This varies quite a lot between different systems. Some video visit systems are easier than others for you and your patients. Some have apps to download or logins with passwords. It's easier if they don't. Some work on any devices, others not. Automatic appointment reminders can help reduce no-shows. Virtual waiting rooms are also helpful for patients and docs. You can see who's online and ready, and patients can get an idea of where they are in the queue. Most video systems have a chat box so that you can type messages back and forth, which often comes in handy. And you can send files or documents to each other, like notes, forms, pictures, or handouts. Virtual could also enable group visits when this wouldn't be possible in person. Here's a screenshot of a visit that I had with a patient who was in hospital and his wife who was at home. He'd just been admitted after a fall and she was at home worrying and wondering how he was doing. He connected on his iPad and she connected on her computer. They totally busted some myths about seniors and technology. Like a lot of seniors, they'd gotten used to Zooming or FaceTiming with their grandkids, so this was fine. And here's a screenshot of a meeting that the dietitian and I had with the patient. This can work really well. Is there good support? Will you get help with installation and customizations to match your schedule and preferences? Will there be training and help with workflows? How will patients be onboarded? And will there be real-time support for you, your staff, and your patients? And cost is always a factor. Check for additional costs. Training and support and certain features might not be included in the base pricing. Virtual care has led to the development of a new set of clinical skills. First of all, there's webside manner. In addition to the usual skills of bedside manner, there are other factors to consider when doing virtual visits, especially video. Things like making sure that the camera is near the video image and looking into the camera so that you're making eye contact. Having good lighting so that you can see each other clearly. And being comfortable with the technology so you can focus on the patient. These are some good examples of how to optimize your website manner. Provider-directed patient self-exam is also an important part of virtual care. Limited but effective physical exams can be conducted during a video visit and even during a phone visit. This certainly wasn't something that I learned about in medical school more than a few years ago. But now, evidence-based guidelines for virtual care physical examinations are in the early stages of development. A good example of this is the Stanford University School of Medicine instructional videos on physical exams. Here's a clip of one of their videos.
Low back pain is one of the most common reasons that patients come to see their doctor. Using the video visit format, you can very easily have a patient do the core elements of a physical examination to help inform your decision making. In this case, Maya is here to see me because she has pretty bad low back pain, so we're going to find out a little bit more about it, cutting directly to the physical examination. Maya, welcome back to Stanford Video Visits.
Yeah, thank you. Good to see you again.
Yeah, I'm really sorry about your back pain.
Yeah.
So can you show me where it's hurting you?
Let me put my phone down so I can
Okay.
see you better. You can see it better.
That sounds great.
All right, can you see me?
I can.
All right, it hurts right about here.
Okay. So I appreciate the fact that you're sitting down. With your back pain, are you able to stand up?
I think so.
Okay. Can you
Yeah.
turn around perhaps and show me exactly where it's hurting on your back?
Right
Right
here.
here? Okay, that's great. That's
Yeah.
very helpful.
A little lower maybe, right
Little
there.
lower?
Yeah.
Okay, good. That's the area that hurts? Okay. We're going to do a little bit of palpation. Are you able to reach your arm behind your back?
Yeah, I think I should be able to do
Great.
that.
Okay, so if you can, I'm going to have you turn your back towards the phone. Very good. Okay, and I want you to start right in the middle, right kind of underneath where your hand is. Just go right to the spine. Perfect. Okay, and I want you to just push all the way down your spine until you hit your tailbone. Okay, does it hurt anywhere there in the middle?
No, there's no pain.
Okay, good. Let's go to either side. Let's have you press down on the right side,
Yeah, that hurts a bit.
right there. Okay.
Yeah.
Okay, that's helpful. So can you go down a little bit further all the way to your pelvis?
Yeah, that's okay.
Okay, all that's
Hurts right
area?
there.
Okay, great. And let's try the other side too. You can use your other hand if that would be easier
good.
for you. Great. And I'm going to have you push all the
That's
way
fine.
down. Okay. Okay, well, I'm glad that you're not having any pain lower down. Sometimes it's a little bit difficult to do via a video visit. We're going to start off with a couple maneuvers. The first is I'm going to see how much range of motion you have in your back, okay? Could you turn so that your side is facing the phone? Terrific, okay. I'd like you to put your hands at your waist and then just bend down from your hips all the way down until you can almost
That's a
touch your
little
toes.
stiff.
It's a little stiff? Okay,
Yeah.
okay. You're doing great. Okay, if that's as much as you can do?
Yeah.
Okay, good. So stand up, don't hurt yourself, please. Take one step forward. Very good, okay. I'd like you to put your hands on your hips again. And if you could, I'm gonna have you just lean backwards.
Okay.
Is that as much
Yeah, it
as you
hurts
can
in
do?
the same
right
area.
there? Okay, good. So don't hurt yourself again. Okay, turn to face me. Great. And we're going to have you just bend side to side. So drop one shoulder down all the way. Very good. Let
That's
your-
okay.
And how about the other side?
Yeah, that's fine
Okay,
too.
great. Bring your arms up. Good. And I want you to keep your hips stable. Don't move them. And then just rotate side to side. Okay, very good. That's terrific. Really appreciate that. Okay. So now we're going to test your sensation just in 3 of the spinal dermatomes, L4, L5, and S1. Okay. So can I see your foot? Can you take your shoe off and I can take a look at your foot?
Can I sit down for that again?
Oh, of course. Yeah, please.
Thank you.
I don't need you to be hopping up on one foot.
Okay, I'll put my
especially
foot
with the
right
back pain.
here.
Okay,
Can
great.
you see it?
I can see it pretty well now, okay?
Okay.
So I want you first to feel the inside portion. I'll bring my foot up too, okay? If you can, bring the inside portion of your heel, of your instep. Okay, how does that feel? Does that feel normal?
Yeah, that feels fine.
Okay, and then I'm going to have you feel right between the web of your first and second toe. Okay, that's L5. Mm-hmm. And then I'm going to have you feel the outer portion of your.
that's fine too.
That also feels okay. The outer portion of your foot, terrific. Okay, so the sensation in your foot is fine, and it sounds like the sensation in the other foot is also fine, which is good. And let's test strength. I'm going to test functional strength first with the get up and go test. So stand up and cross your hands. Perfect. Good. All right. Very nice. Okay, and then I'm going to have you take 3 steps for me. Towards me, and then 3 steps to the side, away from me, so I can see you fully as you're walking. Okay, and then turn around. Okay, very good. Okay, Maya, we're going to test the strength in your legs, and we're going to test just L4, L5, and S1. And cross your arms in front of you again. Okay, good. I want you to squat down, and then stand up. Perfect. That's L4 is intact. If you could now please walk on your heels. Okay, very good. That's L5 intact. And now if you could stand on your tiptoes and then just walk towards me 3 steps. Perfect. S1 looks terrific. And that concludes the back exam.
Links to these videos will be included with this presentation. For virtual visits, privacy and security needs to be a priority with the tools that we use and the way that we use them. Ontario Health has established a virtual visit verification standard and provides a list of verified virtual visit solutions for providers. We can only bill for video visits if we're using a verified solution. Providers and patients also need to understand about how to make sure that privacy is maintained. We'll include a list of references with this presentation. One of the main challenges in implementing virtual care is engagement. There's a general resistance to change and a reluctance to use new technology, especially these days when we're all feeling the strain of the pandemic. Doctors, other healthcare providers, and admin staff need to be engaged. They need to understand the benefits and challenges. Questions and concerns need to be addressed. It helps if everyone's involved in the decision processes. And it's really important that everyone has good training and support. Finding the right approach when launching new virtual care tools can make the difference between success and failure. Be prepared. It's usually best to introduce one new system at a time. Doing a soft launch can also be helpful. When we introduced video visits at my clinic, we started with just a few selected patients in my practice. We then opened it up to all of my patients, and after a few months, we opened it up to the rest of the clinic. This soft launch worked well, and we used a similar approach for a lot of other digital health tools that we implemented. Messaging can also be a very effective way to provide care virtually. Addressing an issue through email or messaging usually takes less time than an appointment, can be done when it works best for you, and often prevents the need for an appointment. Used properly, it's a time saver for us and our patients. Messaging can be secure or non-secure. It's been okay to use regular email or texting, even if it's not secure, as long as patients have provided informed consent and that we use appropriate discretion. But now that secure systems are more practical and available, we're being advised and encouraged to use secure systems when possible. Messaging can be initiated by providers or patients. Provider-initiated messaging can be really helpful. Rather than having a patient book an appointment to go over something, it can often be well taken care of by simply sending a message. Adjusting meds based on lab results or following up about an x-ray. There's lots we can do by simply sending a message. Patients can also send us messages, questions about side effects on a new meds, or sending pictures of a rash or a mole, just a few examples of appropriate messages. And we can exchange documents like forms, notes, and handouts. Docs get concerned about allowing patients to send messages. They think that they'll get too many messages and get overloaded with more work. We can avoid this, though, by making sure that patients understand what the messaging is for and to keep the messages short and simple. If a message is too long and detailed, or if it seems like the concern requires an appointment, we can just message them back to book a visit. Done properly and appropriately in many situations, messaging can save time and be the preferred form of care for patients and providers. E-consults are another form of messaging. Referring a patient to see a specialist can mean long wait times, being limited to specialists who are in the area, and the need for patients to be able to get to the appointment with the specialist. With an e-consult, instead of referring a patient to see the specialist, we can send the patient's information to the specialist and ask for their opinion. In my system, they just added an e-consult button to the patient charts in the EMR. So now I can type my question in the EMR, mark any notes to attach, and then just click the e-consult button. This launches the e-consult with all of the information included, so that I could choose the specialist or specialty group and then send it. Easy. The specialists usually respond within a few days and send me a consult report, which gets posted to the chart. I get good advice about how to manage the patient, and I can follow up with the patient to provide them with care far sooner and more easily for them than a traditional consult would have been. E-referrals are another good example of communication between providers. When an appointment with a specialist is required, rather than faxing a referral to the specialist, we can send an e-referral electronically instead. In my system, there's another button in the chart for this too. I flag any chart notes or reports to attach and then click the e-referral button. This takes me to the Ocean Health Map, which allows me to easily find specialists. The map even shows us the patient's home and where it is in relation to the specialist. It also shows details about the specialists, their particular areas of focus, and even average wait times. Depending on the situation, sometimes I'll choose a specialist who's closer to the patient, and sometimes I'll choose a specialist who's farther away but has a shorter wait time. It really helps to have this information available when making the referral. When sending the e-referral, it automatically pulls up the corresponding referral form, fills in the patient details, and attaches anything that was flagged in the chart. It can also pull in a patient summary, or CPP, Cumulative Patient Profile, and labs just by clicking a checkbox. No more fumbling for forms, and it checks that the forms are complete, so we don't get referrals bouncing back asking for missing information. A note about the e-referral is automatically added to the chart, and there's an option for it to notify the patient as well. They aren't set up for all specialists or services yet, but it's getting there. We're also using e-referrals a lot to order diagnostic tests and imaging. For this as well, it really helps to have locations, wait times, automatic referral forms, and patient notifications. Real-time messaging between providers is another helpful component of virtual care. As a family doc trying to connect with a specialist on call, or as a hospitalist trying to connect with a family doc to arrange for follow-up after discharge, rather than trying to get each other on the phone or by paging or faxing, there are apps now that allow us to use secure texting to connect. The app I use is called Hypercare, and it's similar to WhatsApp, so it's familiar and easy to use. It helps that it has a built-in scheduler, so I can check my own schedule or easily find who's on call to connect with them. And it has lots of other helpful features, like setting your status to show if you're not available or away, and forwarding messages to whoever's covering for you. It meets the required privacy and security standards, so it's okay to include personal health information about patients in the messages. Appointment booking helps patients, staff, and providers. And it's also a form of virtual care in that it involves electronic communication between patients and providers, which can result in improved care. It can be accessed from a patient portal, or in this case, from an office website. It can be much more convenient for patients. They don't have to call, they can choose from a list of appointments, and they can choose the type of visit that they need. It's also much less work for staff, not having to field phone calls and negotiate appointments with patients. We can control which appointments are available online and set restrictions about how far in advance they can be booked and how many can be booked at a time. The system can also prompt the patient with online questionnaires corresponding to the problems that they're booking in for. If a patient requests an appointment for a possible bladder infection, they're automatically asked to complete a bladder infection questionnaire, and their responses go right into the chart. These online questionnaires are referred to as e-forms in my system. They can be linked to the online bookings, and they can also be sent to patients through secure messaging. They can be shared between clinics and customized as needed. Here's what a typical chart note looks like after a patient has completed an online booking with a questionnaire. The booking note, the questionnaire, and the picture are already in the chart for the appointment. This saves a lot of time during the visit, so we can spend more time focusing on what needs to be done. Remote patient monitoring, another form of virtual care, is becoming more practical and more accessible. Here's a short video clip presented by Canada Health Infoway.
My name is Joy Williams. I'm 61 years old. I've been living with diabetes for about 20 years and I've been insulin dependent for the past 5. My osteoarthritis developed to the point where I started walking with a cane. I wasn't able to play with my granddaughter. That was really terrible because she's a very important person to me. Somewhere along the line, I had to take a big lifestyle change.
In Eastern Health, we have an aging population and many patients have more than one chronic disease. And in order to support those patients with chronic disease, we have to have innovative solutions to reach them in their community. Access to service is challenging because of the rural geography. Providing service and health services to them where they live is really important.
It's probably the biggest, I would say the biggest innovation going on now in virtual care at a patient's home. You can be anywhere in the province and get the same standard and same level of care. That's one of the big things.
The Remote Patient Monitoring Program is an innovative program that uses technology as an enabler to provide coaching, education, support, and behavior modification, as well as monitoring for patients with chronic disease. Joy really embraced the program. She really embraced the education that she was receiving through the iPad, and she really linked in with her nurse.
Depending on my answers to the questions would be prompt whether I would get a phone call from my nurse.
The program is teaching people how to self-manage their own care, their own disease.
The daily monitoring and teaching you all the skills that you need to better get a handle on your chronic disease is what makes the program so successful. It was really comforting, I guess, to me to know that somebody out there was going to help me through this.
They can recognize symptoms very early, act on them earlier, and prevent an ER visit or an admission, which is a very high cost to the system. It certainly decreases travel for both the patient and the clinician, and it can decrease the number of visits that a patient has to have. Since the implementation of the program, we've seen a 13% reduction in ER visits.
She always used to say Nana has her walking stick. And when I stopped using it, she was so pleased. Nana, she said, you're learning to walk without your stick. So that made me really happy.
The use of digital health solutions is the way of the future if we're focusing in on patient care.
AI is playing more and more of a role in our daily lives, and healthcare is not going to be an exception. Medical chatbots are coming online, and this too can be a form of virtual care. For example, apps are already available that can be used by patients as symptom checkers. The chatbot can take a medical history, provide information about possible conditions, and recommend next steps. There are definitely pros and cons to this, but it's happening. Patients are already doing this, and we need to do what we can to make it as safe and effective as possible. I've been impressed with a chatbot called Wobot that does effective evidence-based cognitive behavior therapy. Here you can see how well it responds. It's designed to be empathetic and positive when appropriate. Take a moment to read this section of the chat. It continues here. It seems to understand well and directs the therapy based on the user's responses. You can try it by just downloading the app. It's totally free and easy to use. One of the main challenges of virtual care is knowing when it's appropriate. Opinions differ depending on the circumstances, but there are some good basic principles. First and foremost, it's about patients. What is their preference, access, and ability? For clinicians, it's about what's available to us, our competency with various types of virtual care, and judgment about what's clinically appropriate. There's no standard set of conditions which are considered appropriate or inappropriate for virtual care. Some are more amenable to in-person than virtual, but it really depends on the circumstances. We need to keep in mind that it's not binary. It doesn't have to be one or the other. We can start with a virtual visit and transition to an in-person visit if necessary. There are some excellent guides on the appropriate use of virtual care. Healthcare Excellence Canada and Canada Health Infoway released their Clinician Change Virtual Care Toolkit. And Ontario Health just released their guidance document on the clinically appropriate use of virtual care. They both have helpful, practical tips about delivering safe, effective, and appropriate virtual care. References for these will also be provided with this presentation, and they are very much worth reading. We also need to do what we can to make virtual care as equitable and inclusive as possible. In this context, equitable means that everyone has the opportunity to achieve their optimal health outcomes regardless of potential personal, social, or structural barriers. This certainly needs to be addressed when it comes to virtual care. Barriers can include disabilities, distrust in healthcare providers, systems, and technology, lack of access to technology and data services, as well as challenges with tech. There's lots we can do to help break through these barriers to virtual care at all levels, including individual, health system, technology, and social structure. An excellent guide on this is included in the Clinician Change Virtual Care Toolkit that I just referred to, which also includes a link to a very insightful video webinar. It's also worth noting a few other good references. OntarioMD has a website, ontariomd.vc, with some excellent practical tips about virtual care. And the Canadian Medical Protective Association, or CMPA, the legal support for physicians, has an excellent website on the medical legal aspects of virtual care. This includes helpful tools such as a template for patient consent to use virtual care tools. It explains why consent is needed, how it can be obtained, and how it should be documented. To help ensure that we are able to provide virtual care to our patients, there needs to be funding for this. We need to be paid for virtual care to cover our time and the costs of implementation. A quick fix temporary funding model for virtual care came into effect at the start of the pandemic to support the sudden switch to virtual. In December 2022, though, a virtual care funding framework was implemented. Here's a simplified explanation of some of the highlights. Video visits are paid at the same rate as in-person visits. Phone visits are paid at 85%, but 95% for psychotherapy and psychiatric care. To qualify for these fees, there must be an existing and ongoing patient-physician relationship. This means that there has to have been at least one in-person visit in the past 24 months, or that the patient is enrolled in the practice. There are also fees that can be billed even without an existing ongoing relationship for a very limited set of services. If there isn't an existing patient-physician relationship, which could happen with virtual visit walking clinics, for example, then we can only bill for limited virtual care services. $20 for video and $15 for phone. Practically speaking, these are very low amounts, and the ministry seems to be signaling to discourage the use of virtual care unless there's an existing and ongoing patient-physician relationship. This has been quite controversial, and the ministry has agreed to make exceptions to this in certain circumstances in which virtual is pretty much the only option. And here are some of the other eligibility criteria. The virtual visit must be appropriate. It can be patient or physician initiated. We can't bill for just administrative type interactions, like advising about an appointment. The physician and patient must be physically located in Ontario at the time of the visit. In-person services must be made available within a clinically appropriate time frame if medically necessary, or if at the time of scheduling the patient prefers an in-person visit. And we must use a verified virtual visit solution. These are listed in the Ontario Health Virtual Visit Verification Standard that I referred to earlier. There is also a pilot project to pay us for secure messaging. We are going to get paid for using secure messaging to provide care. It's going to be done on a monthly threshold basis as shown here. As we've discussed, secure messaging can be an effective and even preferable method of providing care virtually, so it's really encouraging to see that the ministry is starting to recognize this. Before closing, I want to leave you with some tips about virtual visits. I can tell you're excited about this, so here are some practical tips to help you all be virtual stars. Review the guidance documents. This will give you a good understanding of how to make the most of virtual visits for you and your patients. Be familiar with the technology. Practice. Set up a test session with a colleague. Be the doc and also try being the patient so you know how it looks for them too. Make sure there's a good setup. The guidance documents have lots of good advice about this, like making sure that you're in a private space with no distractions. Document the visit the same way as you would for an in-person visit and also include virtual factors. How was the appointment made? Was it booked online or through the receptionist? How was consent obtained? What modality was used? Phone, video, secure messaging? Why was this modality used? And was it appropriate? Who was in attendance? Sometimes this isn't obvious, even with video. I found out halfway through a visit that a spouse is sitting behind the camera, listening and prompting the patient. This could be helpful, but it could also be harmful. Perhaps the patient is limiting their responses because someone else is there. Ask the patient. It's good to know who's there and why, and if appropriate, it's usually better to bring them into the visit directly, as if they were joining an in-person visit. How is privacy maintained? I've had patients video me from their car because they didn't have a private space in the house. And speaking of which, I've had patients take a virtual visit while driving. Even if it's just a phone call, it can be distracting. It's better to ask them to reschedule to a better time. Document any relevant social determinants of health. Is there a need for a follow-up visit? And if so, what modality is recommended? So that's a high-level overview of virtual care. To sum it up, virtual care is care. Although it's not for everyone or all situations, and it's not meant to replace in-person care, it can allow us to provide better access to more equitable and inclusive care for our patients and communities. And on a final note, virtual care can be a positive experience for everyone involved, even the pets. It's an amazing time to be starting a medical career. Medicine is evolving and virtual care is here to stay. What's the future of medicine going to look like? That's going to be up to you. Thank you.